Okay, thank you. Again, my name is Michael Goldenberg. I'm president of Health Realty Advisors. We advise hospitals and physicians on what to do with their real estate and then often implement our recommendations. I thought I would today first give you a few stats on the healthcare industry in this community, then introduce our speakers, tell you something about them and their institutions very briefly. It will add some context to our discussion. Then ask them about their outlook on healthcare in general and their own institutions, and maybe speak to some of the growth within their organizations. And then we're going to focus on capital, and that's kind of where you all come in, because one way to access capital is through real estate, and they can help to grow their organizations by accessing and doing business with all of you in this room. Each of the individuals here today run multifaceted, complex organizations that exceed $1 billion in annual revenue, and some of them are approaching $2 billion. They employ over 35,000 people. 4 of the top 10 employers in the city of Philadelphia are healthcare organizations. Healthcare, 26.2% of all the jobs in the city of Philadelphia are healthcare jobs. The average in the national average is 15.25%. So you can see what Philadelphia is #1 in the United States in terms of percentage of healthcare jobs. Over the last decade, healthcare employment in this city has increased 19%, while overall employment has decreased 4%. So imagine what that number would be without healthcare. There are 7 healthcare systems in this city that represent half the hospital beds. An interesting stat in doing my research, and something that would be new over the last 10 years, is roughly 1/3 of the hospitals, or 11, in the city of Philadelphia are for-profit hospitals. And finally, a real estate statistic: over 1/3 of all this commercial space in the city of Philadelphia is owned or occupied by healthcare organizations or higher education. Now I'd like to introduce our speakers and start first to my left with the dean of, because I'm doing this based on seniority, the introductions. Rich Miller to my left has been at Virtua or its predecessor for 26 years. He led the merger of the 2 health systems to form Virtua in 1998. Virtua consists right now of 4 hospitals: Mount Holly, Marlton, and Berlin. But the pièce de résistance is the new hospital that was opened in Voorhees just about a year ago. It's a 368-bed hospital on 125 acres, $463 million project, 680,000 square feet, and a private developer was hired to build the medical office building. I was talking to Rich outside, and in a healthcare career, usually you don't get the opportunity to go to an empty field and build the institution, a healthcare institution of the 21st century. So it's incredibly unusual that we have 2 individuals here today that are, yours was open in May, and in September, Barry Friedman of Einstein will open their new hospital in Montgomery County. Which leads me to Barry. Today is his 9th anniversary as CEO of Einstein. For the prior 25 years, he held various positions at Mount Sinai NYU in New York. He left as president and CEO of Mount Sinai NYU. Einstein has 7 healthcare campuses. He's led Einstein through dynamic change. First interesting move he made was he was a successful bidder for Elkins Park Hospital, which is now the home of the world-renowned Moss Rehabilitation Hospital. He has successfully closed hospitals. One thing we might talk about is that a lot of people up here on this stage have successfully closed and sold, not as hospitals, their former hospital buildings. Barry closed Germantown Hospital, sold to LaSalle University. He'll be in the process of closing Montgomery Hospital, as he will be relocating Montgomery Hospital to Einstein Montgomery in East Norton, which is the first new hospital in Pennsylvania in 10 years, a $365 million project, 146 private beds, and also a privately developed medical office building. Dr. Robert Laskowski is president and CEO of ChristianaCare since April of 2003. He oversees a huge operation. He has a 913-bed suburban campus and a Wilmington campus where they are in the middle of a $250 million hospital addition, which will add 100 private beds, new ORs, and a new emergency room. Interestingly, as part of my research, I found that ChristianaCare does business in 4 states: the entire state of Delaware, Maryland, New Jersey, and now movement into Pennsylvania. Another interesting real estate statistic is they have 70 different locations. And last but certainly not least is Dr. Larry Kaiser. For the last year, just about a year, he is both the CEO of Temple University Health System and Dean of the Temple University School of Medicine. So he is also responsible for academic medicine at Temple University. He's no stranger to Philadelphia, as from 1991 to 2008, he rose through the ranks of the University of Pennsylvania Health System. He's a cardiothoracic surgeon, but also has held a variety of administrative posts there as surgeon-in-chief, chair of the Department of Surgery. In 2008, he became president of the University of Texas Health Science Center at Houston, but fortunately did not sell his house and was recruited back to Philadelphia and to Temple. He has led Temple and pioneered Temple's move to bring its medical excellence to the Philadelphia suburbs and is continuing to do so. And the most dynamic move he is making, and if he has to leave, he's got a conference call on this major transaction. You might have read Temple University Health System is going to acquire a world-class organization, Fox Chase Medical Center. They will probably close in the next month or two, and we might ask Larry to talk about how there's a lot of real estate rationalization in that acquisition. So we first want to talk about each person's outlook for healthcare in general and for their institution, and speak to growth. And so first, I'd like to ask Rich Miller to comment.
Thanks, Michael. First of all, I'll comment a little bit on the healthcare environment and talk a little bit about what we're seeing in healthcare reform. And just to say that everybody's in healthcare is awaiting a Supreme Court decision on healthcare reform. Frankly, the Supreme Court decision, in my mind, is not going to change the direction of where we need to be in healthcare, because we're just too expensive and the cost of healthcare is too high, and we have to change the delivery model anyway. So we're preparing at Virtua to change the delivery model in a different way. And in fact, what we're thinking about is how do we, as a community center, and I think the academics will have a little different spin on this, but as a community health provider in southern New Jersey, our goal now is to kind of flip the model around to wellness and prevention as well. So we're going to take care of sick people in our community, but we're also going to be thinking about how do we take care of people before they get sick. So we've kind of made an investment, Michael, in terms of wellness and prevention. Virtua has 3 health and fitness centers in southern New Jersey as part of our model, as part of our outpatient growth model. So in each county, in Gloucester, Camden, and Burlington County, we've incorporated a large outpatient center with a health fitness model. And we're building nutrition support into that model. And also the other thing we've taken on as Virtua is we self-insured all of our employees to figure out how we can take better care of our employee population. So, we're looking at a different model from our perspective in terms of looking at wellness, prevention, along with sick care. In terms of the hospital model itself, I think the model is going to take a major change in the next 5 to 10 years. And what I mean by that is I think you're going to see a lot more consolidation in healthcare. I think you'll see a lot more consolidation and a lot more closure. If you look at New Jersey's model, for example, right now in medicine, 50% of the hospitals in the state are losing money from operations. So we're at a time right now where the economics are getting worse. We don't, if anybody in the room wants to tell me I'm going to get more Medicare and Medicaid reimbursement in the next 10 years, I'd like to talk to you about that. We're going to get less. The model's going to change. Community hospitals that are smaller in the 200 to 250 bed range will be looking for partners. They should start looking for partners now. It's been slow to move in our state, but I think that's just a matter of time before that happens. From a real estate perspective, briefly, I'll tell you that we have a lot of aging plants in the state. We were fortunate enough to build a new hospital, but a lot of the plants are old and aging. We're going to see a sea change in terms of larger healthcare providers absorbing the smaller provider. Healthcare will still be delivered in local communities, and hopefully the larger providers will have a little bit more capital to spend to look at refresh of facilities. I don't think the bed need's going to grow in the community. I think in the next 10 years we're going to see lesser bed need for inpatient beds. So we're really we're making our bets on the physician and outpatient business for growth. And we're doing a bed study at Virtua right now to determine what our bed needs are going to be in the next 5 to 10 years. My bet is we won't need the beds we have today, and probably we'll be looking at more consolidation even inside Virtua. So inpatient-wise, I think you'll see a reduction in bed need. I think you're going to need refresh in facilities that are existing facilities. You'll see larger providers absorbing those smaller facilities to support the capital needs of those smaller facilities. But the capital needs are great. It's not only building, it's technology and it's growth. So there's a lot of dollar needs in healthcare right now, and unfortunately some of the smaller community hospitals are struggling to stay afloat on the capital front. So I think consolidation, we'll see larger systems growing and picking up more hospitals, and we'll see significantly more growth on the outpatient side of the business and on the physician side of the business.
Thank you, Rich. Larry, one of the interesting real estate opportunities that presents itself is when you close a hospital. What do you do with an old hospital that's not going to be a hospital anymore? And that has become a real estate opportunity. At Temple, they closed Northeastern Hospital and have sold it. And really what kills you is the operating cost of carrying an old hospital. So real estate people know what to do with it, but it does present an interesting opportunity. I'd like to turn it over to Larry to talk about some of the growth plans that Temple has, as was quoted in the paper just a couple weeks ago, of wanting to grow almost double the size or triple the size of Temple University Health System. So, Larry, you want to comment?
Well, I think just to amplify a little bit on, first of all, usually when I'm on a panel, there's a table, because I'm sitting here with my socks lighting up the place, you know. I thought I'd be behind a table, Michael. I mean, sitting here looking at this, you know. Yeah. Have to put a little color in your life, you know. Our business is not all that colorful, I promise you. Just to amplify a little bit about the whole issue of consolidation in the market, I think if you look at the Philadelphia market in particular, we are super concentrated on the payer side. Essentially, two payers control 80% of this market. IBC, the largest, and Aetna coming in second. And 80% of the market is covered by one of those two payers. So super concentrated on the payer side and almost total fragmentation on the provider side. The largest market share is about 15 to 17%, and then you have one provider with about 9%, and the rest of us all have 6 or 7%. So this is a market that is ripe for consolidation. I think you will see significant consolidation in this market, primarily because the economies of scale favor those that grow larger. And we talked a little bit about the capital needs. I think that's going to be continue to be a significant issue, but we have a number of challenges in terms of how we provide care. I think you are going to see much more opportunity on the outpatient side. The payers certainly in this market are already drilling down on us in terms of inpatient stays. What we're seeing is a significant increase in these observation stays. Whereas these used to all be inpatient stays, we are now being paid essentially outpatient rates for what is now still an inpatient stay for patients who clearly would have been inpatients before. So we're getting pushed in the observation direction. And again, when you have payers controlling the market, I mean, that is they're the ones who make the rules. So in terms of our growth potential, I need to be in a position, as do many of us, need to be in a position that if the payers move to these limited networks, that I need to be a must-have. And currently, frankly, I'm not. But if we can consolidate and become larger, then we become a must-have for the payers. So for us, becoming larger, I think, is particularly important. With the consolidation with Fox Chase, we'll be about a $1.6 billion organization. I think that successful organizations are going to need to be in the $3 to $5 billion range. And I think you have seen that in a number of other cities in the country. If you look at places like Austin, Texas, super concentrated on the provider side. And that's where I think you will find the economies of scale that begin to pay. Clearly, we need to look at our costs, as Rich mentioned. The current healthcare environment is not sustainable. Whether the Accountable Care Act goes forward, the changes are already occurring. We're already seeing a decline in healthcare expenditures. It is not sustainable to have healthcare expenditures be 17% of the gross domestic product. There's no other country in the world where that is the case. So we're already seeing the changes. We need to be prepared for different ways of being paid. Right now, being paid on a fee-for-service basis encourages us to do more. If you start bundling payments, you will see a decline in how care is delivered. That's not to say we will compromise on the quality, because the pressure is on us now, and payers are looking at quality and want to pay us based on our performance. So quality and safety and process improvement are particularly important for us. This concept of maintaining wellness and keeping people out of our emergency rooms is one that we are particularly concerned about. The majority of admissions to the Temple University Hospital, obviously sitting in North Philadelphia, come through the emergency room, where many of those people don't have a primary care physician. Our highest costs are associated with care in the emergency department. So keeping people out of emergency departments, keeping them in outpatient clinics, but managing chronic illness is going to be one of our biggest challenges.
Thank you, Larry. Bob, I would like to hear your outlook, and specifically, a lot of the real estate opportunities for people in this room will come on the outpatient side, and when alternatives are looked for off the campus. So I'd like you to both talk about your outlook, and you made an interesting comment to me about medical office buildings of the past and what you're trying to achieve in your new facilities.
Well, thank you. My colleagues are you're very articulate, and my colleagues articulate in their assessment of the environment. And I can add a couple things, I think, in terms of perspective. First of all, one thing I should say is that we you asked about growth a little bit, and growth is a means to an end for us. And I think that, in terms of size, scale, our job at Christianity, and we actually share this mission with somewhat different words with my colleagues up here, is basically take care of people, help them to get better when they're sick, help them to stay healthy when they're well. The growth aspects of it, and as nonprofits, are essentially owned by the community. So the growth aspects are a means to an end, and I do think we have seen a lot of consolidation all over the country. We're going to see more of that. And that is, in some ways, front page news, but I think below the fold type of news. Okay, that I think broad consensus about that. Important to realize, though. The above the fold stuff, my colleagues have already spoken about, and I think that gets to the outpatient thing here. There's change that's done. Okay, when people talk about reforming healthcare, that reform is in progress. The train has left the station, the boat has left the dock. Pick your cliche on this. This is irreversible stuff, driven not by just good intentions. We like to have good intentions, but driven by money. Okay, so that we need to be able to pay for this stuff in the future. Our society is pushing us on that. So it's the strategies then that we employ have to recognize that, and what we do is the news that's above the fold. So it's the content of care and how that care is organized, and that Dr. Kaiser mentioned the significant change. I agree 100% on that with the outpatient versus inpatient, and the structure actually of that outpatient care. Our plans are to make that dramatically different than traditional models, which gets to Michael's point there, and what I mentioned to him on the phone the other day. We at Christianity Care are not interested in building any more medical office buildings. Office buildings that are essentially, with all due respect to the wonderful people in the office, kind of real estate types of things where you've got, we're going to rent this out, we'll earn some money on the rent there, and there'll be a corridor and this practice on one side, that practice on the other side, and those practices may have nothing to do with each other. We'll have, one guy, who's doing, dental work, and then another guy who's doing something entirely unrelated to that. That, I think, that we're not interested in that, because that does not afford the most value to the people that we're privileged to serve. A much more integrated approach that turns out actually to be less costly as well is the approach that we're very, very actively pursuing in all of our projects. So think bigger buildings, integrated services, whether you're employed by our system or not. There are kind of house rules, and if you want to be in this facility, a health center, well, those are rules that you would participate in. Integrated records, shared services, ways of relating to each other, hours. Okay, so why would we build a health, a medical office building that it's inaccessible to people because it's closed when people are most able to get the care? Those things, in our mind are gone, and we're not. So we're thinking bold thoughts of a dramatic redesign of how we organize services. So bigger buildings and shared services and space configurations which facilitate the interaction of us as physicians and other healthcare providers, and at the end of the day are better and easier for the patients we serve.
Thank you, Bob. Barry, I'd like you to give us your outlook, but also address one of the real estate opportunities in this community, as there's a lot of folks out here running around in the retail world for people who are interested in bringing urgent care to the greater Philadelphia community. I'm sure it's incredibly active and already present in South Jersey and Delaware as well, but urgent care does a lot of things that aren't easy to access right now. So could you give the group some insight into that part of the business as well?
Thank you, Michael, and welcome everybody. It's nice to be here this morning. I think what you've heard from my colleagues is dead on point. I think we're all reading from the same hymn book here as to what is compelling change in healthcare in the United States, and the points have been made. It's unsustainable at the federal level of spending. It's unsustainable at the state level of spending. It's unsustainable in corporate America. We can't be competitive globally. And what that translates into is unleashed economic forces, regardless of what happens with the Supreme Court decision, that will compel healthcare to transform itself and to make it a lower cost. That does translate into consolidation of organizations, and for you in real estate, it translates into opportunity. It translates into opportunity because we're going to have to optimize our space. We're going to have to transform our delivery system, and both of those things bode well. Whether we're looking at rebalancing our portfolios from a real estate perspective, taking acute care facilities out, expanding to more access points and ambulatory points of care distributed throughout the region, throughout geography, that should translate into our talking with you about how we access capital, how we can deliver cost at lower basis than the square footage that we're occupying, how we can create these distribution points throughout the region. We currently have more than 100 sites of points of care. We're going to rebalance that portfolio. We'll discontinue sites as we go forward, so that leads into how do we convert those sites, what use. Michael commented for us, we happened to sell a former campus that we were operating that was within 1 mile of another campus. We were able to close an emergency room, consolidate activities over to our core campus, and to monetize that asset. We looked at doing that with a developer who was going to convert it into housing. We looked at doing it with a strategic partner who could not expand from their current campus location, and it ended up that was both a good neighbor policy and a good fiscal policy, and we did a transaction with LaSalle University. But as we look at Montgomery Hospital as an example, and what we're going to do when we decommission that as an acute hospital, we went out with an RFI. We had 16 interested parties. We selected 4 that went through a finalization process. They all chose senior affordable housing of interest, but it does present opportunities. At the same time, we then take that capital that we use, we deploy it back into creating more opportunities in the community, creating ambulatory access points, maybe urgent care centers because they're lower cost than the emergency room, they're closer to populations, but that translates into us needing either your real estate space, your development capability, or your capital. So there are many, many opportunities that I think this will produce as we go through transformation in order to compress the costs and enter into an era of what we're referring to as population management.
Thank you, Barry. Moving to the capital discussion, hospitals have typically accessed capital traditionally 3 ways. Make it from operations, I call that the hard way. Access debt, usually through the tax-exempt debt market, and fundraising. But there's 2 other ways to access capital that are really becoming important, and they do involve real estate. One is called asset monetization, selling non-core assets. That can be real estate, it can be other lines of business as well. And there's been some significant asset monetization, whether it's Northeastern Hospital or Germantown Hospital, Montgomery Hospital. Birchua actually took their Camden Hospital and redeveloped it as a social service mecca. And it eliminates a lot of cost when you're not carrying the losing operations and cost of those physical plants. The other alternative is I call other people's money. So how do they accomplish their objectives by using someone else's money to build a building or lease a building and fit it out and accomplish what their goal is, and their goal is the success of the businesses inside the building. They figured out they don't need to own everything, really can't. So does anyone want to comment about third-party real estate ventures? You have them,
I have a few of them, Michael. In fact, we've done it all the ways that Michael described, and our Camden facility was a facility in the city of Camden. Camden was actually well overbedded, and we closed our inpatient service in Camden back in 2001. And for those of us that have done that and closed an inpatient service, it's probably the toughest thing to do in any municipality or city. But what we actually did was we took the facility and we formed it into an outpatient center of excellence. We have an emergency room, we have a primary care center, we have a dental center, and we took health components, built them into the model, and then we took the rest of the building, and as Bob said, the key is to organize the product in the space appropriately. So we took an educational model, social service model, and a healthcare model, and combined it, and we've leased out about 60% of the building at this point. The whole building is leased, except for our space that we still have in the building. And actually, the Camden model now financially stands on its own. It actually makes money. based on the model that we've put into place. So that's been an outstanding model. On the outpatient side, in the suburban locations, we have 3 major outpatient facilities, ambulatory facilities. They house our health and wellness programs and physician programs. Again, the key there is to make sure the programming, before you start developing the model, that the programming in the center is appropriate for the community. Because sometimes in healthcare we think we know what's best for the community without asking them what they need in the model. So to make sure that the programming is good, it's coordinated in the center, and we've actually used a developer to build all 3 of our major outpatient centers. The one in Washington Township is a 250,000 square foot center. We just opened our new Voorhees Center on our new Voorhees campus, about 300,000 square feet, and we're opening one in Morristown in November that's about 200,000 square feet. Health fitness, we have spa in 2 locations. We're looking at other alternatives to revenue generation and also our healthcare services as well. Just one thing I want to mention when Barry was talking about, we're talking about outpatient locations. To the developers in the room, this is a time I think you have to be more careful in choosing your partners in healthcare. And I'll say that because there's still a lot of independent hospitals out there that have the philosophy is that they build it and they will come philosophy. And they're building centers and outpatient surgery centers on their campuses hoping the community responds to that. And they're using developers' money to do that. That could be a real disaster because frankly, I would walk in the door as a developer and ask what the strategy is for your system for overall growth before you dive into that, because that could be a poor use of not only the community's money, but of your money as well. So just be careful at a time when you have operations that are losing money, they're trying to hold on to market share, they're looking at the build it and they will come philosophy and developing, because that could be a disaster, frankly. Understand the whole strategic plan. I would move more toward the bigger systems in terms of that development need and stay with the bigger systems that have a larger strategy. I think that's important.
Michael, you mentioned the monetizing non-core assets. I mean, the sale of the Northeastern facility, number one, created some political problems with not just with the community, but with the state. And part of that was the way it was handled. But there's another reason to monetize some of those assets if they continue to be money losers by selling them for other development. We actually partially financed that deal as well. Our situation is a little bit unique, and it gets into where we would like to be partnering with private developers. I've got a situation where, despite the fact that the health system is separate from the university, it is a separate 501c3 from Temple University. The university, and there is the corporate veil between the 2 entities, yet the credit rating of the university is certainly influenced by what the health system is doing. And the health system at Temple has lost money in recent years. I'm pleased to say that we are not losing money these days, which I'm pleased about. But the university obviously is very concerned about any additional debt that we take on because of the influence on their own credit rating. The university is not really willing to stand behind the health system in terms of its debt. So I have that issue, and clearly I have some needs on our North Philadelphia campus for some building, and we will be looking toward partnering with a private developer. But it's 100% revenue-generating space right from the get-go, plus the retail space that exists there. And we think that there's some great potential to be able to do something between, certainly going on North Broad Street up to Temple University is an area of increasing development, but we think that that corridor between the university campus and the health system campus and developing the health system campus will be really some ideal, there will be some ideal potential for that, and we are actively engaged in looking at those possibilities right now. We worked with the Payette firm out of Boston to develop an entire plan for the health system campus, and I'm sure many of you will be hearing more about that.
When I've talked to a number of people around the country who are friends of mine, and there's on the other people's money, that there's certainly and many folks in the audience probably can talk more eloquently than I can about this, but a lot of private equity money sitting out there that is finding healthcare development to be very, very attractive. And so you've got Ascension, who's got a new for-profit company, and they're out there buying hospitals.
Stewart?
Yeah, Stewart, yeah, right, you got exactly right. So, and it's, so there is this money looking for a home, and healthcare being such a gigantic part of the economy, even with all the caveats we talk about, looks to be very attractive to the private equity folks. So, so that's something that is, first time in my career that I've really seen that. I mean, so that's pretty interesting. The implications of that, not sure. Flip over here, the other people's money thing, and it sounds good, other people's money rather than the worry I have about other people's money is back to the Rich's point about strategy, and so I think other people's money carrying out a strategy that is consistent, that with strategy of like the organization, that's one thing, but it's easy for me to imagine that the other people's money gets kind of tangled up in other issues, because actually the people's money it is, they want to do different things. So I think that is a caveat for guys like me, and thinking, oh, yeah, that's great, we'll just get some off balance sheet financing for this, everything is good. Well, I mean, it's a more sophisticated question than that. How does it fit into at least different parts of the strategy? Duke's doing it. I mean, they're doing it in the outreach side. They're got like their joint venture. They're 2% owners of this. This is not exactly a big stake, but they view this as being particularly useful for them. So I think this is a lot to be written on this one, and we'll see how that works.
We're at great risk here for you thinking the reason that we were all so eager to be here is to get other people's money.
It is.
We're going to pass a hat, actually.
Larry's doing interviews after this and across the hall.
And to a large extent, that is true. But the reality is, it is good opportunities, and you do have to choose carefully. For us, we did have a developer come in and do our medical arts building that's connected to the new hospital that's opening up in September. Our biggest problem was we oversubscribed coming out of the chute. We didn't have enough space, and we're looking to do a second medical arts building on the campus because we are not able to accommodate the demand that presented itself. Those should be the kind of problems and the kind of investments that you all look for. But to Rich's point, you do want to choose your partners carefully. You do want to see those situations, and you can work with us to create the effective protections that you're looking for while you are providing us the capital that we are eager to have.
I just wanted to make a point focusing on all your comments and a comment that Bob made about the future of how these properties should be developed, because if you want to work in the healthcare field, the true difference maker is not can you access capital. The difference maker is, do you understand the business of healthcare? Because a lot of times I'm the third party that sits between the developer and the hospital. And the developer is a real estate and finance person, and the hospital is speaking English, and the developer hears it as English, but it's really not English. It's healthcare. So they can think it was a good meeting, and I'll say, no, it wasn't such a good meeting. And they don't understand the decision-making process that has to go along. And the product line approach that Bob talked about, how to put people next to other people that relate to each other and deliver a more patient-centered, friendly approach. If you understand that and can deliver that, as opposed to just bringing your capital to the table, putting a developer at risk is not something that ends up being in the benefit of the hospital. So the hospital helping in putting the product lines into the building that are going to spin the business off to them, that's the benefit of the medical office building, not the real estate. So
yeah, something I can add to that too, Michael. I think it's important as developers and financing folks in the room that one of the things you're going to find in healthcare, and I think Larry said it in his comments, is that the economics are going to consolidate in the future. The bundling of economics will consolidate. So when you think about the continuum of care, the front end of care, hospital care, home health, long-term care, the bundling of those economics will occur at some point. Now, what does that mean? And we saw it when we built our new hospital in Voorhees. The amount of long-term care development now on the Route 73 corridor has dramatically increased. So if you're looking at the tangential product to hospital care, start thinking about the fact that there's other development besides the hospital development that will develop because those providers are thinking. For example, I've been approached by 2 or 3 large skilled nursing facility providers saying, hey, Rich, I want to talk to you about how do we work together because I'm building right next to you. And the thought process is, I need your patients. We know the economics are going to be aligned with you, so how do I work with you? So think beyond the acute space if you're thinking about supporting development. It'll go well beyond acute into other facets of care, and you'll see that development. And I'm sure, Barry, you're seeing it in your marketplace where you're building, and that's something to think about just beyond the acute space.
Okay.
This is one of the most creative times I've seen in the system design in healthcare. I mean, it is the most. Okay, so the healthcare system is loosened up. I mentioned that earlier in a way I've not seen before. So I'm speaking for myself. Creative. This is a time for creative ideas, not and they're the ones that I think are going to have an opportunity to thrive in ways that say 10, 15 years ago they simply would not have had that opportunity. So creativity is something I'd encourage.
Quick question. Tell us who you are, too.
Hi, my name is Rich Gottlieb. I'm with Keystone Property Group. You've focused on the hospitals, but the doctors themselves, are they going to start getting bigger? Yeah. Are they bundling as well? I mean, what's your perspective on that? And are the hospitals looking to own the doctors, or are they going to be independent?
So the alignment between physicians and hospitals is something that has been that figures in a major way into everything that we do now. And if you look around this market right now, most of the primary care physicians are already owned. Many of the specialty groups want to be owned. Cardiology, for instance, is a specialty where the revenue has been drilled down and where they clearly need to be and are very interested in being owned. So you are seeing more and more providers owning physicians. All of us have networks. This is a different environment than it was in the 90s when many of us began to buy up physician groups, competing with each other, overpaying for them, not setting up an incentive structure that would incent them to be productive. But there's absolutely no question that if we're going to look at different ways of being paid for care, like bundled care payments, the hospital and the physicians are going to have to be very closely aligned to do that. Those of us who essentially own all the doctors, that they're full-time employees, have it a little bit easier than places where there's a totally independent medical staff. Even there, that alignment has to be in place, and even in those institutions, and certainly my colleagues can comment, there is a move to own not just primary care providers, but some of the specialty providers as well. So most independent physicians are looking for some way of stabilizing their revenue. The nasty little secret is nobody wants to talk about the fact that physicians likely are going to be earning less money. No one wants to talk about that in the United States these days, but that's just the way it's going to be as we see reimbursement cut back. Certainly with the federal budget, you're looking at cuts in payment to Medicare providers, Medicaid. That's a whole different story. But yes, that alignment between physicians and hospitals is occurring as we speak.
Yeah, I would agree 100% on that. If people 9 years ago asked me, like, who's your competitors in Delaware, I'd kind of look down the hallway and say, well, that would be my colleagues on the medical staff. They're building surgery centers, all types of stuff. Those days are gone. Maybe they come back, but they're gone now. So the alignment of us all, I think, is 180 degrees from what it was. And then the economics of our growth in our own medical group here, the biggest growth has been in specialty services of folks that we didn't actually solicit. They just come banging on the door saying, hey, listen, we want to be in, we want to be more integrated, we want to deliver care in ways that we're not slaves to a fee-for-service system. Very, very different rhetoric than 10 years ago, entirely different. And primary care in our community still, other than the medical group of Christiana Care, pretty highly fragmented with onesies and twosies. Those physicians, my colleagues, friends, they can't recruit anybody. They have to consolidate or they won't exist. Okay, so consolidation among physician in the physician land, that's happening, and it's happening, as we speak, and in areas which are resistant to it, it will happen over the next several years, very precipitously.
Other comments? We've got two amazing panels to follow, but other things that haven't been said that are really important. Okay, one more question. Where did you? Okay, here we go.
Hi, I'm Paul Whitson from Skidmore, Owings and Merrill. I have a question about standardization of care delivery, whether you're going to ask physicians to follow certain models according to disease processes or any of those kinds of alignments where you're going from more cowboy-like to more pit crew-like physician structure.
Physicians, by and large, have been very resistant to outside influences telling them how to practice. But we're seeing more and more standardizing care and evidence-based care, buzzword that you've probably heard. There's absolutely no question if we're going to control costs, we need to look very specifically at issues of care management. How many tests we order, why are you ordering that test, what are you going to do with that? And that's something that most physicians have resisted being told. I was involved in developing what we had to call practice guidelines in thoracic surgery because we couldn't call them requirements, because if you didn't do it, were you liable for something that you didn't do. So we called them guidelines as such. But I think we're clearly seeing, and in my own institution, we are looking, we've taken care of revenue cycle, we've taken care of supply chain, but now we're down to care management and how you actually care for the patient and how you can further reduce costs associated with an incident of care. So yes, we're seeing lots of that now, and looking at the resistance that's being put up by individual practitioners.
I think also to that end, the key here is the growth in information technology now in healthcare has led us to better information. And I think my physician friends on the panel will agree that in years past, when you approached your physicians about their issues in patient care, the answer would be, my patient's sicker than other doctors' patients. And now with information that we have available, we've kind of taken that jargon out. So, I have to say the physician community has responded in a real positive way to this. Physician order entries become part of the IT staple in most of all the hospitals sitting here, and we have better information to manage. And our physician community has responded. Just one comment on the salaried physician model and what we're seeing on hospitals acquiring physicians. To the answer to the back of the room, that will happen. If you asked me 10 years ago, I think it was about 8 years ago, I bought my first surgical practice, and I still have the scars on my back to show for it, because we had a completely independent medical staff at that point. Today, frankly, the cardiology section chief is an employed physician, and our chief of medicine is an employed physician. So times are changing, physicians are more accepting, and in fact, at this point, they're banging our doors down to say, we need to work with you guys. Let's get in here. And to Bob's point, the onesie and twosie private practice physicians, primary care physicians are really struggling right now. They just don't have the wherewithal for an IT system for growth, and they're going to be needing a system to support them. So a big change in the physician marketplace.
Barry, did you have a last comment?
Just back to your point, and I'll take a very futuristic view. For those of you who remember Star Trek and the physician Bones, he would take out his little scanner and would assess all the diagnostic aspects of that patient and what they were presenting. and you get a computer algorithm response. That is not something that we won't see, whether it's 20 or 30 years. But the information technology capabilities that can assess all the variables that go into any condition a patient presents should be able to spit out the probability and best pathway based on evidence-based medicine and what's been proven to date. And there is resistance to that, but you will not be able to resist the technological advances that are coming over the next decades.
If there was something left unsaid, that's good. We'll have to have a sequel to the icons of healthcare, and to the guy who herded the icons, Michael Goldenberg, a very, very big thank you. Next panel, come on up.